Our next segment is Vasa Previa. Vasa Previa, as you can see, is a very uncommon event. 1 in 3,000 deliveries. Many obstetricians will go for an entire career without ever seeing Vasa Previa. And this is our case, and it has the classic triad, which you must remember. A 21-year-old gravid 1 at 38 weeks gestation is admitted to labor and delivery at 6 centimeters dilation with uterine contractions occurring every 3 minutes. Everything looks good. She's at term, she's in the active phase of labor, she's having normal regular contractions. Artificial rupture of membranes is performed, which happens all the time. Except in this case, immediately after artificial rupture of membranes, there is bright red vaginal bleeding. Numero uno, artificial rupture of membranes. Numero dos, vaginal bleeding, followed by the electronic fetal monitor tracing, which had showed a baseline fetal heart rate of 135 with accelerations. Accelerations are always reassuring. Now shows a bradycardia, 70 beats a minute. And interestingly, mom's vital signs are stable. Normal blood pressure, normal pulse. Remember those three: artificial rupture of membranes, or it could be spontaneous rupture of membranes, followed by vaginal bleeding, followed by bradycardia. What's your diagnosis? Vasa Previa. Here's what we've got. Here is the main disc of the placenta. This is a succenturiate or accessory lobe, and these are joined by a blood vessel which overlies the cervix. This is going over the membranes. If this membrane ruptures and if the vessel gets ruptured, whose blood is this? Fetal blood. Now, what is the blood volume of a fetus? It's about 90 to 100 milliliters per kilogram. Let's take a term baby, 3 kilos, 300 cc's is a blood volume. What if 200 cc's of blood is lost? What's going to happen? This baby's going to die. It's going to exsanguinate. This is going to be a post-mortem diagnosis. What is the character of the bleeding? Painful or painless? Painless bleeding. Uncommon, but painless bleeding. Where is the placenta? Is it going to be normally implanted, or is it going to be in the lower segment? Normal implantation. See, it's a blood vessel which runs over the cervix, not the placenta. Pathophysiology is bleeding fetal vessels which traverse the fetal membranes. It is these vessels which are unprotected by the Wharton's jelly and by the umbilical cord, which then get ruptured. The diagnostic triad, which our case presented very nicely: rupture of membranes, followed by vaginal bleeding, followed by bradycardia. If you see this on the exam, you got the diagnosis. Risk factors. Filamentous cord insertion. I'll show you what that is in just a minute. Accessory placental lobe. I'll show you what that looks like. Multiple gestation. When you have twins or triplets, you have much higher rate of filamentous cord insertion, much higher rate of accessory placental lobe. What is the management? Now remember, with abruptio placenta, we had a number of possibilities. With Vasa Previa, only one: crash, cesarean. I mean, we're looking at seconds, minutes to get this baby out. And if you don't, you're going to lose it. I was on call some time ago, and the resident called me and said, I just ruptured the bag of waters, there's bleeding, and there's bradycardia. I said, take her back to the operating room, tell the NICU, the neonatal intensive care unit, they're going to have a hypovolemic baby, have just uncross-matched blood available, and let's see if we can save this baby. In 90 seconds, we had the baby out, and it survived, fortunately, but it was like a rag doll, hypovolemic. Most of these babies do not survive. Fetal death from hypovolemia is the worst complication. And unfortunately, it's very difficult to make the diagnosis. If we consider this the placenta with the vessels, and here is the accessory lobe, they are joined together by a vessel which runs across the fetal membranes. This is a placental accessory lobe. But if you get rupture of the membranes right here, that's Vasa previa. The other possibility would be a subcentrial lobe. This shows the subcentrial lobe. This shows the main body of the placenta. Now let's look at filamentous cord insertion. Here we have a normal placenta, and here's the umbilical cord. Notice the origin of the umbilical cord is on the disc of the placenta. With a filamentous cord insertion, the umbilical cord takes its origin on the membranes. Here is the disc of the placenta, and here are the vessels. And notice how they go across the fetal membranes, and it's not till over here where the umbilical cord takes its origin. What if we have rupture of the membranes right here? That's going to be a Vasa previa. And let me show you what a filamentous cord insertion looks like. You can see this is the disc of the placenta, and look at how these vessels traverse the membranes, and the umbilical cord doesn't take its origin until way up over here. If you should have rupture of any of these vessels, it's going to be over as far as this baby is concerned. Here we have an artist's conception of a filamentous insertion. Here is a placenta, here's the umbilical cord, and notice how these vessels are on the membranes in front of the fetal head. This is the internal cervical os. This was an ultrasound which showed a Vasa previa. Now, without color Doppler, you wouldn't have a clue that there was a vessel in front of this head. But when you look with color Doppler, here is a vessel in front of the head. There is no cervix. There is no placenta there. This is the kind of case where you want to alert the obstetrician. Don't allow a vaginal delivery here. You want to do a scheduled cesarean, usually around 37 weeks. Now, if we put an ultrasound Doppler gauge right here, what are we going to get? And this is a rapid fetal heart rate, consistent with the fetus rather than the mother. And that confirms that this must be a Vasa previa. So remember, amniotomy, rupture of membranes, followed by painless vaginal bleeding, followed by fetal bradycardia, you've got Vasa previa. And that needs quick emergency care. And that's the end of Vasa previa.